you. Thank you, everyone. First and foremost, I would like to really thank Heartland Rehab for having me here today, and I want to start by really congratulating them. 7 years of, I'm sure, very hard work, and really nice to see your baby now having legs from crawling to walking to now running, hopefully. And so I'm going to be talking about knee preservation, which is what I'm passionate about. It might sound a little bit antithesis to what all of us are familiar with, which is knee replacement. So yes, I spent 2 years of my career unlearning what I was trained for and unlearning what I did in SGH, which is to replace knees, and I tried to figure out how we can extend the COE of the knee. Right, we're all very familiar with cars, and I often, when I converse with my patients, I actually draw parallel to how we can get a car to run for as long as possible, and similarly, car actually in Hokkien means leg, right? So yeah, so I tell them how we can extend the COE of their leg or their knees. So this is a little bit of a philosophical approach to what I think would be the future of knee surgery or knee preservation. And I know we are celebrating 7 years of physiotherapy services with Heartland, and I often tell my patients that surgery is only half of what the journey is, and the other half is actually physiotherapy. So in the field of knee preservation, I think physiotherapy is also extremely important. And up till today, we have come through robotic surgery, we have had injections, we have cell-based therapy, but if you look at evidence and literature, still the only level A evidence, or the strongest evidence there is for knee arthritis, is weight loss and physiotherapy. Not even surgery comes close in terms of level 1 evidence in showing the efficacy and how effective it is. So you guys here are doing very important work. Next slide. Next one. Next slide. Next slide. So this was actually the history of knee preservation. 415 years before the birth of Christ, Hippocrates had already written about how they actually treated people with deformity. So they put us on this, what looks like a torture device, and they essentially used metal bars and rods to essentially straighten bones when people came in with bow-leggedness or legs that didn't look quite straight. So it's essentially revisiting old principles but applying modern techniques to achieve better outcomes. Next. But really, it was during World War that we found out that we could save knees that were damaged beyond repair. And this was during one of the wars in the 17th century, where Langenbeck, all those of you who maybe have some experience with surgery, Langenbeck is actually the name of a retractor that we use in surgery, and it was founded by this famous German surgeon. He was a bit cowboy and basically cut open soldiers who were injured during the war and fixed them with plates and screws to try to straighten out knees that were badly damaged by war. He had some limited success, but found that patients died because of infection. Next. Next. And it was not till in recent times where we found that antibiotics were the solution to some of these surgeries that we do today, and that really changed the perception of open surgery in correcting deformity. Next. So if you know, osteotomy surgery, for those of you who don't know, is basically breaking bones and setting them from a crooked shape to make it straight. So when you do that, we need implants to actually hold them while waiting for the bone to develop. And osteotomies had a very bad name in the earlier part of this century because there just weren't implants that could hold the bones together. So this was in 1940s. This is a gentleman's name is Coventry, and he invented those staples, very similar to what we use to staple our papers, just perhaps 10 times thicker to hold pieces of bone together. And you can imagine, if you walk on it, it's often going to break and not withstand body weight. So patients who had osteotomy had to be casted and were told not to walk for 3 months. After the end of 3 months, obviously the bones healed, but their knee became as stiff as a log and they couldn't walk anyway. So there wasn't any point straightening out the knee if they couldn't walk on it. So it became unfavored, unfortunately, and went out of fashion. Next. So we knew that knee preservation worked, but then we forgot the whole concept of trying to be natural and saving what God had given us. Why? Because of the obsession with robots. Because we were so used to replacing knees, and because the industries have been pushing robots in recent years to do knee replacements and hip replacements, it became the surgery of choice. So if today you go to any knee surgeon with knee arthritis, if the surgeon is trained in arthroplasty, you'll invariably ask to go and consider knee replacement, right? Many of you may have parents who have maybe even undergone knee replacement. Now don't get me wrong, I actually do knee replacements quite a bit in my practice. It's a great operation, but just like any other thing in our lives, it is great when it's done at the right time for the right patient. Nowadays we're seeing patients too young in their careers having knee replacement done, and therefore they find that they're not getting the satisfaction out of the knee replacement. A knee replacement, if you look at it, lasts for about 20-25 years. And if you're going to be getting it at the age of 55, with life expectancy now hovering at late 80s to early 90s, you're bound to need a second knee replacement in your lifetime, and the outcomes of that are just not as good as the first one. Next one. So we can see, and it's no surprise that from 2019, you can see a steady uptick of the number of knee replacements being done, not just in Singapore, but worldwide. And this is really driving healthcare costs up, and not just in terms of economic cost, but also manpower cost, and also utilization of hospitals. Beds get taken up for these surgeries, and you can't just keep building hospitals to suit this. Next. This really is the problem. For anyone that gets a knee replacement under the age of 75, they have a 3 times higher risk of needing a second replacement in their lifetime. And you can see the projection of revision knee replacements from 2025 on how extensive it is if we continue replacing knees in patients who are younger and younger. Right? You're not just going to be going through 1 knee replacement, you're going to be going through 2, and some of them even 3 knee replacement. Now, why is that a problem? If you know how a knee replacement is done, the metal is bonded with your bones with cement. Literally cement, right? When you go for a second knee replacement, they have to remove the implants they put in first. And that implant is not going to come out nice and clean like a banana skin off your banana. It's going to come off with your own bone. And therefore, when you do the second knee replacement, we have to replace your own bone with more metal. So you end up with a bigger implant and a higher risk of infection and early failure. So now that's the problem. Next. So this was a study. It's a study published in Lancet, no less. Trust me, not many orthopedic papers get published in a journal like Lancet. So if an orthopedic paper gets published in Lancet, everyone actually stands up and reads the paper because it's almost like a miracle, right? This study had close to 55,000 patients. And this is where they showed that anyone less than the age of 70 getting a knee replacement immediately is at a 35% risk of getting a second knee replacement in their lifetime. That's really something was scary, and that's what jolted me into action to see how can we find an alternative solution to knee arthritis, especially in those having arthritis when they are younger than the age of 75. Next. Next. So this, you can see that osteotomy has been on the decline and arthroplasty has been on the rise, and these are global data. And therefore I went on a journey. I went to go and look for someone who was doing knee preservation surgery, and that brought me to London, where I was exposed to the art of preserving the knee, and I spent a good 1.5 years there picking up skills in trying to extend the health span and the lifespan of the native knee. Next. So I tell all my fellow colleagues that it's time to awaken, not to ditch knee replacement, but to really consider knee replacements only when the patient has exhausted all other options, including physiotherapy, including bracing, injections, and consideration for alignment correction before we consider replacing their knees. Next. So today, this is how I do my osteotomy, right? It's with a very minimally invasive implant. The implant is about 3 centimeters in length, It takes a 4 centimeter incision to perform it. It is done away from the joint. Therefore, you don't have to worry about infection within the joint, which would set you back from getting a knee replacement. So it is a solution that doesn't burn bridges. And all the problems I spoke about earlier in terms of infection, in terms of implant stability, we have managed to overcome those by having modern implants that are strong. We have injections that we can give to prevent infection, and we also have courses available for surgeons to pick up the skills so that they are adept at doing this surgery faster and with precision. Next. I won't bore you with the science, but suffice to say, I'll summarize all these studies in just one anecdote. If you go today for a knee preservation procedure such as an alignment correction, we tell our patients that your chances are 85% success at 10 years. Now, what does that mean? If you today went for a knee osteotomy or a realignment procedure, out of 10 patients who go for this procedure after 10 years, 8 of them will still have their natural knee. 2 of them might have succumbed to getting their knees replaced. Now you might think that doesn't sound like very optimistic, but think about it from a perspective of someone who is 55 years old. They have an 8 in 10 chance of still keeping their natural knee after 10 years, as opposed to getting their knees replaced 10 years prior. So you're essentially buying them 10 years with their natural knee, which to me is a bet that I'll take if I was asked the question. Next. Okay, continue. Let's just summarize all these. We can continue. Yep. Next. So this was me in 2019 in London, and I had the pleasure of meeting many people in Europe, and Europe has really led the charge in saving knees. It's predominantly because it's culturally people want to continue working and continue being active. So I have seen patients when I was on fellowship, an 85-year-old lady that is still climbing mountains and didn't want a knee replacement, and she had an osteotomy done, and it's really a lifestyle choice. So while age, as we mentioned, often is seen as a chronological thing, but really, true age of someone is really depending on what their function is and what they want to achieve out of their lifestyle. And therefore, all of us need to have very frank conversations with the people that we serve and really try to serve them for the purpose that they want their needs for. Next. Anyone afraid of blood and gore? Okay, good. Then we'll just play this surgical video. Okay, I think the rating for today is below M18, so we shall skip it. Oh, okay, it's working. So sorry. Yeah, so bear with me. So these are literally the instruments that we need. This is a saw that we use to cut through the bone. And so here we are making a cut through the bone, and what we'll be doing is opening up a gap on the inner part of the bone. And these are done with, yes, they're called chisels. And orthopedics is often known as glorified carpentry for a reason. So what I'm doing now is, with this wedge put into the bone, I'm checking on X-ray if I've corrected the alignment from a bow-legged one to a straight one. And this is all precisely calculated prior to the surgery. If I'm going for a 7.8 millimeters, I ensure that I get 7.8 millimeters of correction during surgery. And this is us putting in a bone wedge that is made to measure, so that's 7.8 millimeters of a bone wedge being put in and malleted into the space that I've created. Sucking away some blood. But just hold on for a little bit. So that's a wire that we're putting in to protect the hinge. Don't worry, the patient is asleep and he doesn't feel any of this, obviously. Yep.
No humans will harm in the filming.
No, none, except the surgeon. So here we're just stitching up the wound, closing the plate. You can see how small the plate is, and this incision is all but 4 centimeters. Okay, I'm glad you guys had your dinner before this video. And that's the end of the surgery. We go to the next slide. And I just want to show you how it looks like before and after. The next slide. to maybe stop. Yeah. So here we can see this patient's knee prior to surgery. If you follow the green line, you can see that the green line is intersecting the knee on the inner half of the knee, which means when the patient walks, he's putting weight through an area that is already bone on bone, and you can imagine that's going to be really painful. And you can see with the correction of the alignment, I've shifted the green line towards the middle of the knee. So that represents where the body weight goes through when the patient walks with this new alignment. And this will then go on to protect the knee for, in this patient, I think this patient is now currently 5 years after surgery and is doing really well. And really, if you catch these patients early and you do this procedure, I can say with confidence that this patient may not need a knee replacement for the rest of his life. That's really the aim of knee preservation surgery. So this is the bone graft that we prepare to put into the gap. So with the combination of plate and the bone graft, this patient can walk immediately after surgery. Previously I mentioned about the Coventry staple. When we put it, the patient got to be casted and can't walk for 3 months. But with these modern techniques of filling the gap and using plates and screws that are strong enough, this patient the day after surgery is already on crutches and already putting the foot on the ground and immediately can walk and bend the knee. And that's the real advantage of modern techniques. And a little bit about 3D printing technology. So now with the advent of additive manufacturing, I have now moved to using 3D printed scaffolds as such, which saves me about 15 minutes of shaping the bone graft in theatre. And so this is a local company called Osteopore. We're really proud to know that this was actually a master's project that was spin off in 1987 from a group of scientists in NTU. And they were really looking at materials to cover skull defects for patients who had part of their brains removed and they had to reshape the skull. So this amazing product, over a year, it just turns into bone wherever you put it. As long as it's in contact with natural bone, this is a calcium triphosphate with a little bit of proprolactone in a very basically proprietary mix. And because it has a honeycomb structure resembling human bone, it becomes human bone. Next. Yep, next. We go to the future. Yep. Next. So this is a study that we did to show that at 6 months, you can see that the scaffold has actually converted to bone. You actually don't see any evidence of the scaffold or the CT scan. So here you can see the patient after 1 month. You can still see the scaffold. And as you follow through, horizontally, you can see that you don't see the scaffold in later half of the year. So as early as 6 months, the entire osteotomy gap has filled with bone. Next. And this is the cool part of my life, that I get to play with new toys, and this is what we call a patient-specific jig. So what we do for really complex correction, we scan the knee and we send it to our engineers, who then print this jig for us, and this jig has holes in them to resemble the final plate position. So when I put this on a patient's knee and drill the holes and make the saw cut through the implant, I don't even need to shoot x-rays to look at my correction. All I need to do is just fit the plate to the holes, and I'm guaranteed that a correction has been achieved, because this is templated pre-operatively to what I want to achieve. And with this, surgery can be done in half an hour without additional cost. This jig costs an additional $1,000, but I save 15 minutes of operating time, and I'm able to guarantee the correction for every patient that needs this. Next. I think the future of anything that we do today in terms of healthcare can be summarized in these 3 P's. The first thing is to prevent. If we know that we are at risk of developing something, then we want to really prevent it before you actually get the problem itself. I know as a surgeon, it's a bit strange for me to say, but really the business is in trying not to operate on patients as much as possible, in preventing the need for them to need surgery. So with biologic injections today, with physiotherapy, with advanced modalities of trying to treat problems before they even arrive, we're able to do that. For example, we have identified a few genes that predict whether or not we are going to get knee osteoarthritis. But the problem is we do not know who carries this gene and how these patients present. If we can unlock that potential, we can screen huge volumes of people, pick up those who have the gene, and we can try to see how we can then prevent them from getting arthritis. And then obviously we put surgeons out of job, but well, we all want a better world to live in, so I think we'll accept that. And I think precision medicine is going to be the new thing, where we do things specific for patients. It's not going to be a one-size-fits-all approach. Every patient will need a different approach of treatment, and I think it needs to be personalized as well to the patient. No two people are the same, even if they're the same gender and same age. Every 55-year-old that walks through my door has different desires, different functional levels, and they want to achieve different things with their joints, and therefore we need to be able to do the treatment that is bespoke for them. Next. Yeah, this is what I talked about, preventing knee osteoarthritis before it even happens. Next. Next. We've already touched on precision with individual patient-specific instrumentation, and we are even into the era of patient-specific implants, where we are printing plates that are meant to sit on your bone depending on the shape of your own individual bones. Next. Next. And when we talk about personalization, we are not just talking about surgery, but we are talking about supplementation. We are talking about intervening with injections that are purpose-built for your own body. And these services, believe it or not, are already currently available. If you take your blood sample and send this to a company overseas, it's going to tell you what is your genetic profile, what are you at risk of, and what you should be doing today to avoid getting some diseases. For example, one of my friends sent his blood over to an American company that read his DNA sequence and told him that he has a gene that codes for glaucoma, which is increased pressure in your eyes, and says that if you drink coffee, you're going to be at 3 times the baseline risk of developing glaucoma because of the effect of coffee on the eye pressure. So we have already today some of these precision medicine companies, but we just need to wait for more widespread adoption and of course for costs to come down for it to be more adaptable. Next. So this is often a slide I show my patients. Gone are the days where a patient with arthritis walks into a clinic and the doctor tells the patient your only options are either physiotherapy or knee replacement. We have a myriad of options for patients, both surgical and non-surgical, from keyhole surgery to repair your cartilage and your meniscus, all the way to even amputation. We want to keep our patients in the green zone. The green zone is what I call a no bridge burning zone. Whatever we do in the green zone, the patients still have the option of getting a knee replacement later on in life. Or better still, remain in the green zone for the rest of their life. The moment we replace the knee and go to the amber zone, it's a one-way ticket. The patient cannot have their natural knee back again, and if a knee replacement gets infected, they get a fracture, there's only one way, which is to go for a salvage procedure, which is in the red zone because it's just fraught with too much risk. So we want to keep our patients in the green zone for as long as possible until they're at the right age to get a knee replacement done. So I often say to anyone seeing patients with musculoskeletal problem, the knee is an organ and we need to treat the knee like an organ. Just like how we treat heart disease, we need to control your blood pressure, we need to control your cholesterol, we need to control your diabetes. Similarly for the knee, it is not just about cutting the knee and replacing it. We need to manage your weight, we need to make sure you do the right exercises if you're already having knee pain, and you need to treat the person as a whole and not just the condition itself. Next. And this is a Olympic strategy for knee preservation surgeons like myself. You know, we don't just look at the cartilage when the patient comes with knee arthritis. We assess everyone based on their alignment, how stable the knee is, whether they have good shock absorption properties in the meniscus. If that all falls in line, then the cartilage will be okay generally. And now with biologics in terms of injections, we formed this 5-ring strategy to try to save and extend the COE of the knee. Thank you very much. I've come to the end of my presentations. I will be very happy to take any questions you have. If not, let's continue to mingle and have a real fun night. Thank you very much for the opportunity.
Thank you. Thank you, sir. Thank you. All right, I would like to get everybody to